Sure.
Bismillahirrahmanirrahim. Welcome you all to the virtual academic program of Oncology Club. In this era of social distancing, we are trying to get socially connected, and that's why we started this weekly program. So today our program is how should I treat my patient following evidence-based medicine? And today our topic is endocrine therapy in breast cancer. Our faculty is Dr. Tapash Mitra. He is the first faculty from within Bangladesh but outside Dhaka. Congratulations, Tapash, for being with us. He is the Associate Professor of Department of Radiotherapy in Chittagong Medical College. Always a smiling face. We hope you will enjoy. And we have our faculties, overseas faculties, Dr. Zakirullah S.K. Farid and Dr. John Connie here with us. And we are always fortunate to have Professor M.A. Hai with us to guide us as our patron, President of Oncology Club. Now I request Professor M.A. Hai sir to say a few words so that we can start our program.
Bismillahirrahmanirrahim. Welcome all the participants. Heartfelt gratitude that you have come, you have joined. You are joining and giving us encouragement for continuing with this webinars regularly. Without the delay, I want to start immediately. Kamal, please start immediately.
So thank you, sir. So our program is for 90 minutes. We want to contain the presentation within 15 to 20 minutes, and there will be some comments, and half an hour will be question answer this, and we'll have a quiz discussion on endocrine therapy. There will be quiz, and then we will wrap up. And as we know, we have some faculties, foreign faculties are 3, and local, all the participants up to assistant professor are treated as faculties, and all the postgraduate students and postgraduate doctors below the rank of assistant professor are treated as participants. So we appreciate that the question answer will be more from the participant, answer will be the faculties. The quiz is open for all. So that's all. So now I stop my screen and I ask Tapash to share his screen and start his presentation. Dr. Tapash Mitra. Share his screen.
Can you hear me? Hello, can you hear me?
Yes.
Yeah.
Okay, thank you very much.
Please, sir, maximize your slide.
Maximize my slide.
Okay, it's okay.
It's
Okay.
Thank you very much, Kamal Bhai, for your introduction. Respected Professor M.A. Hai sir, honorable faculties from home and abroad, dear participants. I, Dr. Tapash Mitra, Associate Professor of Radiotherapy of Chittagong Medical College, welcome all of you to this virtual academic program. It is my great pleasure to become a speaker in front of such learned audience. I also give my special thanks to Dr. AFM Kamal Uddin for its continuous support and encourage me to become a speaker in this program. Today, next 20 to 25 minutes, I shall discuss on endocrine therapy in breast cancer. Outline of my today's discussion is introduction about endocrine therapy, types of endocrine therapy, interpretation of hormonal receptor, endocrine therapy in DCIS, adjuvant, neoadjuvant, and metastatic settings. Introduction. Endocrine therapy for breast cancer is a treatment for breast cancer that are sensitive to hormone therapy for breast cancer work by blocking hormones from attaching to receptor on cancer cell or by decreasing the body's production of hormones. About 75% breast cancer are hormone positive. There are mainly 2 types of hormone receptor positive cells, estrogen receptor positive and progesterone receptor. The goal of endocrine therapy is to reduce the amount of estrogen or progesterone in body. So what is the importance of endocrine therapy? It prevents the cancer from coming back, decreases the risk of cancer developing in other breast regions, slow or stop the growth of cancer, that has spread or reduced the size of tumor prior to surgery. What are the types of classification of endocrine therapy? There are mainly four hormones are responsible, mainly estrogen, progesterone, LH, RH agonist, and androgen. The classification are anti-estrogen. Within anti-estrogen, there are two: selective estrogen receptor modulator and selective estrogen receptor degrader. Aromatase inhibitor, within aromatase inhibitor, non-steroidal aromatase inhibitor and steroidal aromatase inhibitor. And progesterone, that is medroxyprogesterone and minestrol acetate. And ovarian function suppression is the oophorectomy, radiotherapy ablation, LH-RH agonist. Within LH-RH agonist, leuprolide and glucosamine. What are the side effects of the hormonal therapy? There are many side effects. Most common are vaginal discharge, vaginal dryness, and importance in men and breast, importance in men with breast cancer. Less common but serious, that is thromboembolism, endometrial cancer or uterine cancer is mainly looked for when we treated with the tamoxifen, and osteoporosis we shall look for the AI, that is reduce the bone mineral density. Interpretation of hormonal receptor test. There are mainly two types. One is the already scoring system. Their total score is 8. Out of them, 0 to 2 is the hormone receptor negative, and 3 to 8 is the hormone receptor positive. And another one is the ISS scoring system, where ISS scoring system is mainly done by a percentage that tells how many cells out of 100 staying positive for hormone receptors. Their result is 0 to 1% is the negative, and 1 to 100% is the positive, ER positive. And within these, 1 to 10% is the ER low positive, and more than 10% is the ER positive. What are the indications of endocrine therapy? Main indications are luminal type A, B, and HER2 enrich. Now we discuss on different settings. Endocrine therapy in DCIS. In NSABP B24 trial, which is a double-blinded randomized control trial, 1,804 DCIS patients who completed the breast conservation surgery and whole breast radiotherapy who are received tamoxifen versus placebo. After follow-up, less ipsilateral and contralateral breast cancer events are seen in the tamoxifen group. This benefit is mainly on the ER-positive DCIS patients. In view of recent evidence, AI is superior to tamoxifen in the treatment of postmenopausal women with ER-positive invasive breast cancer. This trial supports previous one. That is, out of 3,104 DCIS patients who completed the BCS and radiotherapy, randomized into either tamoxifen or anastrozole. Median follow-up was 9 years. They are seeing the significant difference in the breast cancer-free survival in favor of anastrozole group. It is mainly seen in the postmenopausal patients younger than 60 years. What guideline recommend? After diagnosis of DCIS, with primary treatment with lumpectomy or plus radiotherapy or mastectomy, patient should get the endocrine therapy for 5 years. Tamoxifen for premenopausal women and tamoxifen or aromatase inhibitor for postmenopausal women. Endocrine therapy in breast cancer in adjuvant setting. Tamoxifen and aromatase inhibitor are the current principal anti-hormonal therapy used as adjuvant. 1980s, there is a Swedish trial which compared the tamoxifen 5 years versus 2 years. Here, 5 years was superior to 2 years in terms of event-free survival and overall survival. This result was confirmed by the group trial. NACBP B40 extension study was the first large to assess the benefit of continuing tamoxifen beyond 5 years in the adjuvant setting. Following the NACBP B40, 5 years of tamoxifen was established as a standard treatment in the adjuvant setting. And after that, researchers searched for whether the adjuvant tamoxifen can be extended. So they look after this randomized trial of ATLAS. Their interpretation of that, tamoxifen to 10 years rather than stopping at 5 years produces a further reduction in the recurrence and mortality, particularly after year 10. This ATOM is another trial which is done in the UK, almost similar design, and recruited 6,539 women with ER-positive and unknown early breast cancer. Here, the risk ratio for recurrence was 0.85 with the absolute reduction of 4% with longer treatment. Third generation aromatase inhibitors such as anastrozole, letrozole, or exemestane are more powerful alternative to tamoxifen in postmenopausal women. A recent 10-year update of ATTACK trial, it compared 5 years of tamoxifen to 5 years of anastrozole, showed a relapse rate difference 2.7% at 5 years and 4.3% at 10 years in AI group. Then they come from the, in case of premenopausal women, about the ovarian suppression. Is ovarian suppression is helpful for the premenopausal patient? To diagnose these, this sort of text trial was done. Here, in one group, there is the tamoxifen alone. In other group, the tamoxifen plus ovarian suppression. And another group, the exemestane plus ovarian suppression. Among premenopausal women with breast cancer, the addition of ovarian suppression to tamoxifen resulted in significantly higher 8 years rate of both disease-free and overall survival than tamoxifen alone. The use of exemestane plus ovarian suppression resulted in even higher rate of freedom from recurrence. But the adverse events are more higher in the ovarian suppression group than the tamoxifen alone. What guideline recommend? In case of adjuvant treatment, irrespective of nodal positivity or negativity, HER2 positivity or negativity, all the patients after primary treatment should get the adjuvant.
There is some problem. Microphone possibly.
তাপস, আমি তার কথা শুনতে পাচ্ছি না, তাপস।
Should be continued for.
হ্যালো, তাপস। তাপস, তুমি মিউট হয়ে গেছো, তাপস তুমি মিউট হয়ে গেছো। আনমিউট করো।
হ্যাঁ, করছি।
স্ক্রিন শেয়ার করো। স্ক্রিন শেয়ারটা বাদ দাও, স্ক্রিন শেয়ার।
হ্যাঁ, স্ক্রিন শেয়ার দিচ্ছি।
স্লাইডে চলে যাও আবার। Okay.
Sorry for interruption. In case of premenopausal at diagnosis, tamoxifen or an aromatase inhibitor plus ovarian suppression should be given. If the patient is postmenopausal, after the 5 years, aromatase inhibitor for 5 years should be continued or consider tamoxifen for additional 5 years. If the patient is remain premenopausal, consider tamoxifen for additional 5 years to complete the 10 year or no further endocrine therapy. In case of postmenopausal at diagnosis, aromatase inhibitor, there are several combinations. Aromatase ছবিটা না আমি দেখতে পাচ্ছি না। এটা সরিয়ে দেন না, আপনি কিন্তু চলে আসবেন, সরিয়ে দেন। না এটা সরিয়ে দেন। হ্যালো, ক্যান ইউ হিয়ার মি? হ্যালো,
Please continue.
in PO24, whereas the objective response rate is in case of letrozole versus ovarian tamoxifen. In case of letrozole, it is 55 versus 36%. In case of downstaging to BCS, it is 45 versus 35%. That it is statistically significant. But in case of impact trial, there is anastrozole, tamoxifen, and tamoxifen plus anastrozole. This is not so much significant. But in case of Russian trial, exemestane versus tamoxifen, where objective response were response in case of exemestane is 76.3%, and in case of tamoxifen is 40%. So we can say that AI is superior to tamoxifen in the neoadjuvant setting. Which aromatase inhibitor should be given? SOG Z1031 was the only study prospectively designed to compare the exemestane, letrozole, and anastrozole in the neoadjuvant setting. Here, in this trial, objective response in case of exemestane was 62.9%, letrozole was 74.9%, and anastrozole is 69.1%. No statistically significant difference in clinical response or surgical outcome. So it can be said that all the three hormone therapy may be given in neoadjuvant. What is the optimum duration of neoadjuvant endocrine treatment? Though most of the trial is for 3 to 4 months, their recommendation is treat patients for at least 6 months. Beyond 6 months, continue neoadjuvant endocrine therapy until maximum response or up to a point where BCS become possible. Always a decision to be taken in conjunction with the surgical team. Is there any biomarker for response? We know that in case of neoadjuvant chemotherapy, PCR is considered as validated endpoint for long-term outcome. But in case of luminal breast cancer, there is no such marker. One is interesting candidate parameter is that Ki67, which is expressed during all cell cycle phases except for Z0 and is considered a surrogate of cell proliferation. Some consensus has been found in ESMO and St. Gallen's. What guideline recommend? In same guideline, which shows that preoperative endocrine therapy alone may be considered for patients with ER-positive disease based on comorbidities or low-risk luminal biology. Now the endocrine therapy in metastatic setting. There is a Cochrane database system review where there is a paper on chemotherapy alone versus endocrine therapy alone for metastatic breast cancer. The reviewer's conclusion is that in metastatic breast cancer, where hormone receptor are positive, policy of treating first with endocrine therapy rather than chemotherapy. In fourth ESMO International Consensus Guideline for advanced breast cancer, which shows that endocrine therapy is the preferred option for hormone receptor positive disease, even in presence of visceral disease, unless there is any visceral crisis. Visceral crisis is determined by several organ dysfunction and assessed by sign, symptom, and laboratory functions and rapid progression of the disease. Now come what treatment should be done. AI versus tamoxifen, which is mostly preferred. There are randomized phase 3 studies on aromatase inhibitor versus tamoxifen, which shows that there is no such overall response is slightly better in AI than the tamoxifen. In aromatase inhibitor versus fulvestrant, this This is a Falcon trial where it is a randomized double-blind phase 3 trial where it is randomized between the fulvestrant versus anastrozole group. Here we see that median progression-free survival was 16.6 months in case of fulvestrant. In case of anastrozole, it is 13.8%. But without visceral disease, it is about 22.3, and anastrozole is 13.8 months. So it is seen that without visceral disease, there is a large benefit, but in case of with visceral disease, benefit is less. Now come from single agent to combination agent. Is fulvestrant AI versus AI alone? This is a trial of SWOT SO2246 phase 3 study where randomization done between the anastrozole plus fulvestrant versus anastrozole. Here the median progression-free survival was 15 months for combination group rather than single agent in 13.5 months. And median overall survival was 47.7 months versus anastrozole 41.3 months. There is a hazard ratio is 0.81, which is statistically significant. In case of postmenopausal patient with CTK inhibitor plus AI versus AI alone, it is a Palomar 2 study where there is a palbociclib plus letrozole versus palbociclib plus placebo plus letrozole group. This primary endpoint was the progression-free survival, and secondary endpoint was overall survival. Here it shows that the in progression-free survival, in case of palbociclib plus letrozole, 24.8 months. In case of placebo plus letrozole, it is 14.7 months, which is statistically significant. Trials in premenopausal patients, ER positive and HER2 negative. There is ribociclib plus tamoxifen or a non-steroidal aromatase inhibitor in the first-line setting of which is called the Mona Lisa 7 trial. Here, the patients are randomized into 1:1, and in one group the tamoxifen or non-steroidal aromatase inhibitor plus dostarlimab and ribociclib. In another group, there is tamoxifen or non-steroidal aromatase inhibitor plus dostarlimab and placebo. In case of ribociclib group, there is median progression-free survival was 23.8 months. In case of placebo group, it is 13 months, which hazard ratio is 0.557, which is statistically significant. CDK4 inhibitor plus fulvestrant versus fulvestrant alone. It is a Palomar 3 trial where palbociclib plus fulvestrant. This is a randomized double-blind phase 3 trial where in one group the palbociclib plus fulvestrant, in another group there is placebo plus fulvestrant group. Here median progression-free survival is 9.2 months in palbociclib plus fulvestrant group. In placebo plus fulvestrant group, it is 3.8. Hazard ratio is 0.42, and it is statistically significant. In case of ribociclib plus fulvestrant, in the Mona Lisa 3 trial, here the patients are randomized into ribociclib plus fulvestrant versus placebo plus fulvestrant group. Here progression-free survival is 20.6 months versus 12.8 months, which is statistically significant. Role of mTOR inhibitor. There is a Bolero 2 trial where everolimus plus exemestane versus placebo plus exemestane group. Here the median progression-free survival is 10.6 versus 4.1. That is everolimus plus hormonal group, which is also statistically significant. So in metastatic setting, we can say that endocrine therapy rather than chemotherapy is preferred in the hormone receptor positive metastatic breast cancer, where chemotherapy may be offered with visceral. A combination of AI plus palbociclib should be the preferred first-line hormonal therapy for hormonal receptor positive metastatic breast cancer. If palbociclib treatment is not feasible, AI should be offered. In patients with bone-only disease, fulvestrant may be offered. So what guideline recommend? If there is visceral crisis, go for chemotherapy. If no visceral crisis and prior endocrine therapy within 1 year, if the patient is premenopausal, ovarian ablation or suppression plus endocrine therapy. If the postmenopausal patient should go for only endocrine therapy. If no visceral disease or no prior endocrine therapy within 1 year, in case of premenopausal patient, ovarian ablation or suppression plus systemic therapy, that is endocrine therapy or selective ER modulator. In case of postmenopausal, this endocrine therapy. In case of progression, if endocrine therapy refractory, consider additional line of endocrine therapy. That is, if there is P1K3CA, there is targeted therapy should be included. Otherwise, this systemic therapy. If clinical benefit do not found within 3 sequential endocrine therapy, then go for the systemic therapy. And if the visceral crisis, directly go for chemotherapy. And if chemotherapy does not work, then go for the supportive care. In case of hormone receptor positive case, in case of hormone receptor, the difference is only HER2 targeted therapy should be included here. What are the endocrine therapy? The first line endocrine therapy is AI plus CDK4/6 inhibitor, or fulvestrant plus AI, or fulvestrant plus minus AI. Single agent non-steroidal aromatase inhibitor or steroidal aromatase inhibitor. In case of second line, fulvestrant plus CDK4/6 inhibitor, PIK3CA mutant tumor, PET, LPL6 plus fulvestrant, or in BRCA mutation, this olaparib may be given. In single agent, non-steroidal aromatase inhibitor or steroidal aromatase inhibitor may be one other options. In HER2 positive case, aromatase inhibitor plus minus trastuzumab or aromatase inhibitor plus minus lapatinib may be given. So what is the difference in man with breast cancer? The options are same almost with women, but when men take aromatase inhibitor, they should take a treatment to block the testosterone. Aromatase inhibitor will not stop the hormone-related cancer patients. So at the end of my presentation, some take-home message. Patients with ER positive, PR negative, ER positive cancers can be considered for endocrine therapy. AI is superior to tamoxifen in DCIS, adjuvant and neoadjuvant setting of postmenopausal breast cancer. Endocrine therapy is preferred over chemotherapy in hormone receptor metastatic breast cancer without visceral crisis. Combination of AI and palbociclib is preferred first-line therapy for hormone receptor positive metastatic breast cancer. Premenopausal women need to undergo ovarian ablation before starting on AI and with palbociclib. If palbociclib treatment is not feasible, AI should be offered. In patients with bone-only disease, fulvestrant may be offered. Chemotherapy followed by endocrine therapy should be the sequence as endocrine adjuvant therapy. Sequential or concurrent endocrine therapy with radiotherapy is acceptable. Consider adjuvant bisphosphonate therapy in postmenopausal patients who receive adjuvant endocrine therapy. Thank you very much for your patience here.
Thank you, Tapash. Now the floor is open for question answer. So we welcome questions. So during this time, John, would you like to make few comments, quick comments when the question is coming up? John, are you there?
I am. Sorry I was late this morning. I thought the talk was obviously very comprehensive, covered really the fundamentals of endocrine therapy in the breast cancer setting, early metastatic, and highlights the huge change that we've seen in the last 3 years, I would say, with the adoption and integration of CDK4/6 inhibitors, and how that really has kind of revolutionized the early treatment of patients with metastatic ER-positive breast cancer, and have really become a fundamental treatment now in these patients, which has been great for patients and for clinicians. Really good talk. Thank you.
Thank you, John. So there is a question, Tapash. What is the definition of visceral crisis? Mostafa Aziz Su.
I have given my lecture about the visceral crisis. Visceral crisis means when the patient is investigationally or clinically, you have think that there is a rapid progression of disease. That is, in case of lung, there is the pleural effusion, rapid deterioration. In case of liver metastasis, there is increase in the SGPT, SGOT, and there is rapid deterioration of disease. Then it may be called the visceral crisis.
Okay, so we can say that only organ involvement is not visceral crisis. There should be adequate toxicity like enzyme depletion, or there is obvious symptom. Okay, Lima, I'm coming back to you, but before we have some question in chat box, so let me address that. Nusrat Haq, can you please unmute and ask your question? Nusrat Haq. My question.
Sir, my two questions. One, I want to know about the extended adjuvant hormone therapy and where we will use it. And I'm confused some that where we can use the tamoxifen. In premenopausal women, we usually use tamoxifen. But they are in all studies showing that aromatase inhibitor is superior after ovarian suppression.
Extended endocrine therapy means where we give the hormone therapy for 10 years. I have given you a different trial, that is Atlas and Atom trial, where it shows that the tamoxifen for 10 years is superior prognosis than the 5 years. It may be given in different setting with AI plus tamoxifen or tamoxifen alone. In case of premenopausal patient, we should give the tamoxifen for 10 years. But if the patient is postmenopausal, then it may be given in tamoxifen plus AI or AI plus tamoxifen in different setting, 2 years or for 4 years. That is this extended endocrine therapy. And another question is, what is the?
Sir, then when we will give the ovarian suppression and give tamoxifen or AI in case of premenopausal women, all patients.
In case of premenopausal women, we should give. There is a trial I've given it here, that is soft trial, where this tamoxifen plus ovarian suppression is better than the tamoxifen alone in case of premenopausal patient. This both tamoxifen plus ovarian suppression is better than tamoxifen alone.
Okay. Sir, I can understand. Thank you very much.
Seema, Shahid Alam, you have a comment.
Okay. So with this two questions, I just want to add that should we be using the 10 years of hormone therapy for all the patient or some selected group of patients, especially the aromatase inhibitor? Is there any data of using 10 years superiority of aromatase inhibitor for 10 years and for all patients?
There is no. I have not find any type of trial, but it may be given in different setting. That is aromatase inhibitor for 5 years, followed by tamoxifen or tamoxifen.
Okay, Lima, add here. The answer is
Hello?
that.
I can add.
Hello. Do you hear me?
Yes, please.
In case there is no such trial where this I don't find that any trial that which is given the AI for 10 years. But a recommendation is that it may be given in different forms, like tamoxifen followed by aromatase inhibitor, or aromatase inhibitor followed by tamoxifen in maybe 2 years aromatase inhibitor followed by tamoxifen for another 5 or 6 years, or tamoxifen for 5 years, aromatase inhibitor for 3 years, aromatase inhibitor for 5 years.
So
Okay,
this is
Lima,
for only high-risk patient with node negative positive patient, not for all patient, no?
Yeah, Lima, that is what I'm going to supplement with.
Sorry,
Tabu.
I can't hear anything.
All of us can hear you. So the comment is that extended AI or tamoxifen have some survival benefit, but it is not supposed to be given to everybody. We need to select the patient, discuss with the patient.
That's right.
Because the benefit is only 3 to 5%, and there are some cost about it, and there are many trials for AI especially, and we will discuss that AI, there is no known duration. It is not 10. Tamoxifen, there is 10. AI, somebody says that 7 and 8 you can finish, but so as you said, only for the high risk node positive patient should be selected for.
Given 10 years.
Okay, there is a, Farid, you raised your hand, but I want to hear from you also. Any experience about neoadjuvant hormone? Make your comment and give a comment on that also. Farid.
Thank you. Excellent presentation, Tapash. Well done. Very comprehensive. You covered pretty much everything. The last question that was, I'll come to neoadjuvant hormone therapy. The last question that was asked about extended aromatase inhibitors. I think, is it Paul Gus, that chap was running a trial some years ago. He came to UK with a presentation, I think M17, MS17, something like that. M17. And where he did show extended letrozole therapy, 10 years, has got benefit, but for some reason it didn't complete. But in July 2016, on New England Journal of Medicine, the journal published that extending aromatase inhibitors adjuvant therapy for 10 years. And the duration of AIs, they suggested the extension of treatment with adjuvant aromatase inhibitors for 10 years resulted in a significantly higher rates of disease-free survival and a lower incidence of contralateral breast cancer, those with placebo. Now, this was funded by Canadian Cancer Society, and so there are published papers, but it's not widely practiced and recommended. So you have to go case by case, and based on their comorbidities, suppose if they suffer with serious osteoporosis and other health condition, there are various other things we need to think about. Now, second point I was asked to comment is about neoadjuvant hormone therapy. To be honest, neoadjuvant hormone therapy is relatively new things, not much talked about and not much practiced. But there are lots of trials that has come out, and they have suggested that, especially ER positive, metastatic setting breast cancers, neoadjuvant hormone therapy actually does better. But I give you some practical examples. What we do in UK. Suppose I see a patient with breast cancer who is ER positive, not like a high tumor load, tumor biology, not like aggressive one. And I discuss treatment option and book for surgery like a wide local excision, SNB or something like that. Now patient says she has got a long planned holiday of a lifetime and she would like to go away for 4 weeks. And normally we book, operation takes about 2 to 4 weeks anyway. And then what we do, fair enough, take this hormone therapy, go away, enjoy your holiday, come back. So we have come across this sort of scenario. Sometimes patients choose, I want to have surgery done by that particular surgeon. Or patient might have got a particular health issues, maybe a cardiac issues that needs the cardiologist seen and managed, and then patient come back for breast surgery, which would require general anesthesia and it will be deemed safer following anesthetic review. In that case, we give hormone therapy and operate patient afterwards. So there are many practical examples you could use this. But simply with, I think, Kamal, have I said enough? I've given enough practical examples.
Thank you, Farid. I think COVID is the best example for this neoadjuvant hormone.
Premenopausal, is there any evidence in case of premenopausal neoadjuvant chemotherapy? Premenopausal case?
No.
Not ideal.
Not ideal.
It is recommended. They said not recommended. So there is a question from Dr. Mohammad Istisfar Hussain from Select. Istisfar, can you please unmute and ask your question?
Thank you, Dr. Tapash, for your very nice presentations. question. There is a little bit complicated to me. Just I would like to know what is the role of luteinizing hormone releasing hormone analog in premenopausal women for ovarian production during chemotherapy.
Premenopausal women for
ovarian production, role of luteinizing hormone releasing hormone analog. There is goserelin or leuprolide.
Yeah. It causes the ovarian suppression. It is mainly done for ovarian suppression. It is mainly done for given for ovarian suppression. In any ovarian suppression, after ovarian suppression, tamoxifen or AI is very much helpful for the premenopausal patient.
Okay, if I can understand, you are asking about chemotherapy. During chemotherapy, it is given to help the lady to keep her fertility. So this is the
fertility preservation.
It may suppress the ovarian suppression, and it will less affect the chemotherapy on the ovary. So there is a better chance of, keeping her fertility. This is nothing to do with this hormone therapy. Okay, so now there is another question from Altaf Hussain Riyad. Riyad, please unmute yourself and ask the question.
Thank you, sir, for a nice presentation. Sir, during your presentation, at the end, you have mentioned about aromatase inhibitor plus CDK4 inhibitor should be used as first-line therapy in metastatic setting. And fulvestrant should be used in case of bony metastasis. So is there any data supporting this, or can I use fulvestrant in case of first-line setting in metastatic setting? Why should aromatase inhibitor?
You may give it in case of I have given the NCCN guideline where there is many other options. That is AI plus CDK4/6 inhibitor plus fulvestrant or fulvestrant alone or fulvestrant plus CDK inhibitor. It may be given, but first choice they say that first choice is AI plus pelvicity. You may give it as a first choice in case of metastatic breast cancer, fulvestrant, singly or with CDK inhibitor.
Then why fulvestrant is choiced for bony metastasis, in case of bony metastasis?
There is no such, I do not find anything why it is so much.
Can I add something?
I just think that is aromatase inhibitor causes the bone marrow bone mineral density, decrease the bone mineral density. So if we add the fulvestrant, it may be better for the bone metastasis case. There is a calcium level should be decreased. Yes,
I want to add something with it. Kamal bhai.
Yeah, please.
Yeah.
I want to add something.
Please go ahead.
Okay. So this is the Parsifal study that was presented in this ESCO 2020, May 2020, that showed that aromatase inhibitor plus palbociclib is superior than palbociclib plus fulvestrant in 32 months of median follow-up. At least 4% disease-free survival, better disease-free survival for aromatase inhibitor plus palbociclib. And there is no difference in visceral or bony metastasis like this type of issue. So this is obviously superior. And as fulvestrant is an intramuscular injection, painful, and it is more costly than AI. So I think AI and palbociclib is the better option than AI plus fulvestrant, according to this data.
Thank you, Lima, for the latest update. There is a question from Arman. Arman, can you talk? Or you are with the PPE? So the question is, a patient on tamoxifen developed endometrial thickening. Should I change hormone therapy? What should be the approach actually? Anybody want to take the answer?
Premenopausal patient. Patient is on endometrial thickening.
With endometrial thickening, what to do? Shall we change? What is the approach?
We may search first. I think we may search by the gynecologist whether it is there any there is colposcopy to see whether there is anything different changes in the uterus. If there is changes, you should go for the AI. Or I do not think that endometrial thickening is one of the factors which causes changing of AI, tamoxifen to AI. Let
me tell you that if patient is on tamoxifen, normally the gynecologists say that if it is 9 millimeter or more thickness, they recommend a DNC. But if a patient is on tamoxifen, they need to do an ultrasonogram. If it is 6 millimeter or more, then they recommend to do a DNC to exclude any sorts of pre-malignant or malignant condition. Okay, so there is a question. I think we have plenty of questions. Tapash could generate many questions. So, Debraj Chakraborty, you have a question. Debraj.
Assalamualaikum, sir. Thank you, Tapash sir, for your excellent presentation. I had a question. Which is the first choice of drug for neoadjuvant hormone therapy?
AI is the first choice, then tamoxifen.
Between the AIs, which would be our first option?
Any of the AI, exemestane, letrozole, or anastrozole, anyone. I have seen a trial that ACOG Z1023 where they shows that there is no significant difference between these AI.
Thank you, Sonia. You have a question, Dr. Sonia.
Sir, Assalamu alaikum. Thank you for a nice presentation. Who are the candidates for chemo prevention? Which agents are used for chemo prevention and how long?
Anybody want to take the question? Dima? Chemo prevention. Who is the candidate for chemo prevention and what is now recommended for chemo prevention? Dima? Can you answer? Who is the candidate for chemo prevention and what is the drug now used for chemo prevention?
Patient chemo Kamal bhai আমাকে বলছেন আমি একদম কিছু শুনতে পাচ্ছি না I can't hear anything.
Kamal bhai.
Okay. Shuman, answer.
Probably right now there is no recommendation for chemo prevention.
John? John, on chemo prevention.
Yeah, so if I'm interpreting the question correctly, it's the fact that we now substitute first-line chemotherapy with first-line CDK4/6, ovarian suppression, if premenopausal, and an endocrine aromatase inhibitor, so to delay the need for chemotherapy. So aside from the patients you mentioned who may have end-organ visceral crisis, so abnormal NFTs where you feel there's a small window of opportunity and you may consider chemotherapy. Is that the question that you're asking?
No, she's asking about chemo prevention. She is not a patient. High-risk group. Who is a candidate for chemo prevention? What drug is recommended? Is there any practice now in routine? So somebody is scared that she may develop breast cancer. Is there any scope for chemo prevention by giving tamoxifen?
I might want to say something, Kamal bhai.
Yes, please.
Okay, it's a quite interesting topic, but I think Tapash has explained everything very well, and thank you very much, Tapash, for that. Now, two things I need to clear. I'm confused as well. One is the chemo prevention, another one is neoadjuvant hormonal treatment. So if you talk about neoadjuvant hormonal treatment, what Fareed said, I agree with that. There's quite a lot of trials actually happen to see whether there is any changes happen if you give chemotherapy, if you give endocrine treatment before surgery, like tamoxifen for 1 month, tamoxifen for 2 months, tamoxifen for 3 months. All these trials show that there is no benefit at all. So there is no real treatment for neoadjuvant hormonal treatment. This is just to clear, at least for now. Now, COVID situation, what you said, Kamal, is correct. We wanted to avoid disease progression. So that's why we gave some patients tamoxifen or letrozole or whatever is necessary to buy some time. But this is not a standard treatment. So, but we have a little bit of time to buy so that we can do operation later on. Last thing is, yes, we do some primary endocrine treatment. There is another treatment, what we give for the elderly patient, when you definitely considering not to do for operation or surgery because they're not fit to go for chemotherapy, surgery, or anything like that. These are all pre-operative I'm talking about. Now, chemo prevention. It was a hot topic in America in 2002, 2004, that time, the breast cancer risk for the patients. In America, they love this medication. So initially, there's about 72 to 75% of the patients were taking tamoxifen, even if they don't have any family history, even they didn't have any high risk at all. But somehow it was like a hot cake selling. Everybody was taking this tamoxifen. But this thing has come down now. Even in America, only 33% or less than 33% people are actually taking it because they found that there's no real, I mean, of course, there's some benefit if you're high risk or you've got a family history. In the United Kingdom, the chemo prevention, we hardly use. I mean, I don't know, we just follow them up. If there's a strong family history, we normally follow them up according to their age and according to the risk criteria. Yes, for do that as well, criteria, and see how much risk they are actually carrying. If they're high risk patient, of course, you can give some chemo prevention. Most of them are premenopausal because you're talking about any family history happens normally within the age of 50. So they normally take tamoxifen. For it, you can add as well.
Thank you. I think it's in the new NICE guidelines. The chemo prevention has already come up, and it's not widely practiced. I understand, and what Zakir Bhai you have said is absolutely fine. But if you look at those family history clinics, quite a few patients are actually getting it nowadays. The problem is most of the family history clinics are run by the trained senior nurses. We may not be directly prescribing, but I have personally and my other colleagues have done it on selective high-risk group of patients who would not like to proceed with any other like risk-reducing surgery. Chemo prevention is given, like usually the tamoxifen. Now, the other thing you mentioned about neoadjuvant endocrine therapy, one of the new textbook that was published, I can read that. And I think I presented this thing on neoadjuvant talking. The neoadjuvant endocrine therapy is emerging as a significant approach to locally advanced ER-positive breast cancer over neoadjuvant chemotherapy. And the ongoing trial is, one is the Alliance alternate trial. It's randomizing patients to anastrozole, fulvestrant, or combination, utilizing biochemical markers. And this would give us a lot more answers. But on the presentation, Tapash showed quite a few, he has cited quite a few publications, outcome like PO24, Impact, PROACT, and they have compared with the, neoadjuvant endocrine therapy. There is quite a few trials actually ongoing, already done and published, which I've mentioned, and then the Alliance trial is already ongoing. So it has got proven benefit. On certain cases where you won't be able to give chemotherapy, obviously you could try neoadjuvant hormone therapy, and it is practiced. But if you compare neoadjuvant chemotherapy, a lot quicker response, obviously. But certain cases, you have another weapon in your hand to use for selective cases. Thank you.
Yes, there still is a trial basis. That's something, so not common practice.
Thank you, sir.
Kamal Bhai, I have a question. Two questions easily. Can I?
Yes, please. Go ahead.
So, Tapash Bhai, according to soft and text trial data, should we be using ovarian function suppression for all premenopausal women? Did all premenopausal women receive the same benefit according to the soft and text trial data, or a subset of patients they will be benefited from this ovarian suppression?
There is HR2 negative, ERPR positive and HR2 negative. Patients got more benefit.
Yeah, all are luminal A, but did all premenopausal hormone receptor positive early breast cancer get the same benefit according to the soft and text trial data? No. I think there is a subset of patients. They are young, less than 35 years, node positive, grade 3, and a large tumor. Only this group of patients, they have a 4% disease-free survival benefit. That means the high-risk patient is just get the benefit, not all the patients.
Yeah, thank you, Lima. It is the high risk group, who have a higher risk of recurrence and also higher burden of disease. So they were a bit more beneficial in the soft and text trial. And interesting is initially it was not beneficial, 5 years data. When they gone beyond 5 years, they've got the outcome. So, the answer is it is not always 2 plus 2. It is always
not offer always all the patients.
You need to individualize. Okay, so there is the question. I think I need to give Ayesha. You have a question, Dr. Ayesha.
Assalamu alaikum, everyone. First of all, a very warm compliments. It was very enlightening presentation. Yeah, I had a few questions. Somewhere I had studied about the use of teramifene in the metastatic setting. So I was just looking if there's any mention about this thing in the presentation that I could not. So I want to hear about that. That what is your view about the use of this teramifene in the metastatic settings? My second question is regarding the response assessment after neoadjuvant hormonal therapy. So as you had mentioned that the Ki-67 is being used as a surrogate marker for the response. So I understand that during the core biopsy, you do the Ki-67, that's the baseline, and then you go for another Ki-67. So what should be the timing of repetition of that Ki-67? As you said that neoadjuvant hormonal therapy should be minimum for the 4 months. So at what time we should go for the repeat Ki-67? And just suppose that the patient comorbidities allow that the surgery cannot be done and the Ki-67 is also not showing any promising response, then at this situation, when we have to continue with the hormonal therapy, then have we to switch to another hormonal therapy? So these are my questions. Thank you.
What is the first question?
First question. My first question is...
What is the first question?
My first question was about the use of teramifene. Just there's a
teramifene.
Yeah, in the metastatic setting. Yeah. What is the role of that?
These all are estrogen receptor modulator anti-estrogen. So it may be used in case of metastatic breast cancer. In case of Ki-67, I have found that this is a surrogate marker of, as you know, the PCR is the more common in case of other hormone receptor, HR2 positive and triple negative breast cancer. But in case of luminal type, there is no such marker. You may do it Ki-67. It is not well accepted nowadays. Still, it is not well accepted, but it can be done. So, in tamoxifen, if we give the endocrine therapy for 6 to 12 months, you may continue it for 6 to 12 months. And how if after 6 to 12 months you may do again Ki-67, or there is a clinically we can judge that is the tumor size is reduced or not. So by this we can understand whether this tumor size is decreasing or not, or by Ki-67 we may get additional benefit.
Dr. Ayesha. Hello,
Yes,
Dr. Ayesha.
Yes, sir, I'm there.
Okay, so regarding the first question, the product, personally, we don't have much experience. Maybe we can ask John whether he has some experience of this. And regarding your second question about Ki-67, Tapash tried to answer. But the problem is this is something interesting, but probably we are not using much. So as Tapash said, some authority is telling that Ki-67 could be a surrogate marker. But as you know, it is not like chemotherapy that it will make a magic and just vanish the tumor. So when we are using, the valid question is, if we need to continue, shall we continue the same product or we change? So I think Farid can make some comment because they have some experience on it. Personally, I have no experience of neoadjuvant hormone therapy. So Farid, would you like to respond to Ayesha? And John, can you answer her first question about the use of this Feriston, this Dormifene?
Thank you, Ayesha. I believe you are one of the foreign participants. Are you from Pakistan? Is that correct? If yes. I got the same Ayesha,
that's
right?
True.
Okay.
That's true.
Thanks for joining. I would start with your last question. I think you asked about elderly patients not suitable for surgery who has got ER-positive breast cancer, you could treat them with primary endocrine therapy. An ideal medication we prescribe is letrozole 2.5 milligram once daily. And there are occasions there would be endocrine resistance, and you must have heard this term. So after a few years, you might, most of the time, I run a clinic once a week where I would have about 5 or 6 patients who would come with like a follow-up, who are on long-term primary endocrine therapy. And I've been running it for almost 17 years, 16 years. And I have seen magic. The magic is this drug actually shrinks cancer to nothing. But I've also seen about a small percentage, I haven't got the data with me in front of me, but I'm working on it. The small percentage of patients who would have drug resistance and then letrozole doesn't work, and then disease progression. You could see palpable lesion to impalpable, and then gradually it become palpable, means drugs not working. Where in that case, the letrozole is I think it is a non-steroidal aromatase inhibitors. You can switch hormone therapy to different, like you can change to exemestane, which is a steroidal aromatase inhibitors, if I'm right. And if you could try it for 3 to 4 months, and if you see disease progression, how do you know it? Clinical and ultrasound, at least you have to have some sort of evidence that it's progressing. Then you can change it to other aromatase inhibitors, or even you could go back to your good old tamoxifen, and it really works. And so that was your last question, I believe. Did it answer your last question, Ayesha?
Yep. There's an ongoing study. Actually, we are also doing the study about the use of Ki67 as a surrogate marker in the response assessment. So it's still in the progress. So what we do is that when we go for the core biopsy, we at that time go for the Ki67. And then I think, as far as I remember, because I was doing this study with my medical oncologist, but then I left my rotation. So they were repeating it after 3 months, the Ki67 again. So I have yet to contact her because I have now completed my fellowship and no more affiliated with that institute, but the study is there. So I will also update you about what's their provisional results. Thank you.
Thank you, Ayesha. But one very important thing about Ki67 is, if we are really banking on Ki67, we need to know who is doing it, because the quality control of Ki67 assessment is very, very important when we are using it as any surrogate marker, because it is not like ERPR. Ki67, I mean, there is a huge lab-to-lab variation. So that is
lab-to-lab variation.
So there's a single-centered study. So it's being done at the same setup in Khan University Hospital, Karachi, which is very much, authentic. Yeah, very much authentic.
Other colleagues, that when they are carrying the message, I mean, Ki67 is a very available thing, but when we are really taking a decision with Ki67, we need to know there is a huge study. They have shown that from lab to lab, from preparation, it makes a big difference. So we need to be very cautious where we are doing and where we are doing the same lab. Because say we are doing follow-up with another lab, then it is a disaster. So that is what I wanted to mention. So I think there is another question from Taslim Hussain.
And the last question from me.
Yeah, okay. Taslim Hussain.
Assalamu alaikum, sir. Thank you, sir. Sir, I wanted to know, in a patient of hormone receptor positive breast cancer with bone metastasis, can zoledronic acid and hormone therapy be used at the same time?
Anybody want to take the question?
Yeah, yes.
I think the hormone therapy may be added with zoledronic acid.
There is no harm.
Okay. I have a question. Last question.
Shahida, last question.
Yeah. So definitely AI is superior than TAM for postmenopausal patient. This is proved. But is there any difference between upfront AI for 5 years and the switch therapy, that is 2 to 3 years of tamoxifen, and then completed the 5 years with AI? Because in our setting, sometimes this 10 taka and 40 taka, it makes a huge difference for a patient. So is there any difference for upfront 5 years or a switch therapy?
Can I comment? Can I answer?
Yeah.
So
obviously.
Big 198 give your answer. Mm-hmm. So Big 198 was a study who was taking care of AI and tamoxifen. So there was some crossover. So unintentionally they have shown that what is the outcome of, only TAM AI, AI TAM, and they found that this switch therapy is not showing any significant difference of outcome. So that is not, going to be a big data. So big 198 have shown the switch is not giving you additional benefit on survival.
No, but switch is not inferior than 5 years of AI. So we
that
can...
is the additional benefit. You can change it, but it cannot give additional benefit.
Because especially when we are not very certain about the menopausal status. Sometimes we are not very certain about the menopause. That time we can, start with tamoxifen and then we can switch with AI.
That is the thing. It is non-inferior, but nothing superior. So you can. So that was the unintentional outcome of big 198 study. So
no crosstalk, please. No crosstalk.
Okay, sir.
I think Professor Khadim has joined.
Sir, Khadim sir joined, sir?
Possibly. I can see his face.
Assalamu alaikum, Khadim bhai. Wa alaikum salam, Farid.
Sir, any comments, sir?
Welcome.
Sir, you joined our session. Thank you, sir. Any comment from you, sir?
On which point? Just I have joined and I have just heard about your opinion regarding the Swiss therapy between the tamoxifen and anastrozole. Because I have seen that this meeting is supposed to start at 4. So accordingly, I connect myself, but I don't know. Possibly you have started earlier.
But I think there was a miscommunication. It started 3, sir. So
I see. That I am only 1 hour late. I have missed the presentation.
So it was endocrine therapy, sir, today.
Yes, but
interesting discussion about new endocrine therapy. There was
in my invitation. It is mentioned that it's 4 p.m.
Sir, I think we are extremely sorry for the mistake, sir, if it happened somewhere, sir.
Assalamu alaikum, sir. Can I explain mistake? Tomorrow, yesterday we have a program at 4 p.m. Maybe you missed up this. I have sent you 2 messages and you missed it.
No. Today's invitation, I noticed that it's 4 p.m.
Sir, I ask apology if it is done, sir. Inshallah, next time it will not be there. So
no mention about that. It's my bad luck that I am 1 hour late joining you.
Sir, it's okay. So if I think we had enough interaction, so can we move to our next session?
Yes, surely. No more discussion on this point.
Okay, sir. So we have a case discussion. I need a volunteer for the case discussion. Anybody? Or Lima or Asma is going to recommend somebody.
Assalamu alaikum.
Walaikum salam. Sonia.
Can I try?
Yes, of course you can. Welcome, Sonia. Thank you for being the volunteer. So 59 years old lady, clear breast, invasive ductal carcinoma T2, 5 centimeter N1 M0 clinical, ERPR positive, heart positive. TI67 is 10%. Obesity with taxane, 8 cycle was given. Then breast conservation surgery with sentinel lymph node biopsy was done. And finally, the result is YPT1, 0.5 centimeter N0 M0. Whole breast radiotherapy and boost is recommended. And also hormone therapy with radiotherapy is recommended. So my question is there any benefit of giving this hormone therapy? I mean, any survival benefit, do you think, Sonia? Like this recommendation. Can hormone therapy give any survival benefit in adjuvant setup?
Yes, sir. Hormone therapy will give survival benefit, disease-free survival, and subsequently overall survival and recurrence, ipsilateral and contralateral breast cancer recurrence.
Do you have any idea how much percentage we are getting benefit out of it? Okay. So is there any effect of age or use of chemo, no chemo, or nodal status on this hormonal benefit as adjuvant? Sonia say patient have used chemotherapy, not used chemotherapy, younger age, older age, not positive, not negative. Is there any effect of it?
Yes, sir.
Yes. Okay. So another small question. Tapash had said that when is ER positive? So my another question is when you say PR positive, what is the scoring that will say that it is PR positive? 1%, 5%, 10% or more? Tapash said if it is 1% or more, then it is, we said, ER positive. But PR positive, what will be the percentage? Okay, so the answer is in PR, anything more than 1%, we can consider 1 to 100% is PR positive. It is important because sometimes we come with a patient ER negative, but still PR positive, we need to give them hormone therapy. So now coming back to the survival benefit, this is the great meta-analysis we always talk, this huge data, and they have shown that 5 years of adjuvant tamoxifen caused breast cancer mortality reduction by 1/3 throughout the first 15 years. And the factor was only hormone receptor positive. There was no effect of PR, age, node, or chemotherapy. So, unfortunately, what you said, we cannot accept. This is irrespective of age, node, and chemotherapy. This benefit of 1/3 reduction of mortality by adjuvant hormone. So, another question is, Sonia, when we are giving an adjuvant hormone therapy to a patient, what are the basic point you want to take care of a patient? I mean, what do you want to take special attention to a patient when you are giving hormone therapy? During surveillance. During surveillance, what do you want to take care? She is taking hormone, so I want to be very cautious. I want to look into this.
Is the patient is premenopausal or postmenopausal?
If it is premenopausal, if it is premenopausal or postmenopausal, what will be the difference? Okay, let me help you. The first important thing is that there are many studies have shown, even we prescribe hormone therapy for 5 years or 10 years, the compliance is not very good. So we need to be very cautious that the patient is very much compliant. That is very important. And when we are giving tamoxifen, already we discussed, there is a high risk of endometrial carcinoma. So once in 12 months, we need to take care of the gynecological examination. And if she is on AI, then we need to take care of the bone mineral density once a year to take care of the bone health.
Also, tamoxifen causes thromboembolism.
Okay, so Sonia, during pregnancy, we know pregnancy and breast cancer is a hot topic. So if you want to prescribe hormone therapy, when you want to give it? First trimester, second trimester, third trimester, or after the delivery? Let me change the question. Is there a detrimental effect of hormone on fetus in organogenesis?
No, sir.
Yes, there is detrimental effect. That's why it is said that in pregnancy, we should give it after the delivery. It should be during postpartum period. And when we give hormone, we say that they cannot be taking any baby during this time because there is an effect of hormone on organ. It is proved. So now the question we already many discussed that what to choose, tamoxifen or AI in a postmenopausal woman?
AI.
What do you mean by menopause? What is the definition of menopause, Sonia?
Patient is 60 years and patient's FSH, LH and estradiol level are within the menopausal range.
Good. So either the patient has done bilateral oophorectomy or age is more than 60 years. You are very correct. If it is less than 60 years, she should be amenorrheic for 12 months or more. In the absence of chemotherapy, tamoxifen, chloromiphen, or ovarian suppression. And if patient is taking tamoxifen, is less than 60, as you said, we need to do the FSH and plasma estradiol level to declare the lady is really at menopause to switch to AI. So tamoxifen versus AI, as you said, that there are this meta-analysis on more matured in Lancet 2015, they have shown that the 5 years of AI versus tamoxifen, that tamoxifen is doing slightly better in this meta-analysis, but it is not conclusive. But when we look in the subgroup in nodal status, you can see that it is not affecting on N0, N2, or N3. In all group, the tamoxifen is doing this. AI is doing better. AI is doing better than tamoxifen because it's the recurrence rate. So you can see in all the group, but it is doing better when it is in bulky node disease. So the recurrence is low in AI compared to tamoxifen. So as you said, AI is doing better. And also in differentiation, if you look that the AI is doing better in poorly differentiated group compared to well-differentiated group. So if you want to choose AI and tamoxifen post-mortem, the greater the absolute risk of recurrence based on pathological feature, the larger the absolute benefit from adjuvant AI versus tamoxifen. With high risk feature, prefer AI over tamoxifen. With a small cancer, favorable pathological feature, unlike to derive relevant difference in recurrence between AI and tamoxifen. So when we are choosing AI, as Lima was telling, we should be choosing the high burden, high risk group. So do you like to make a combination of tamoxifen and AI, which Dr. Shahida was asking? Or you want to give only tamoxifen or only AI?
Combination.
Combination. So, BRIGMA 198 trial, already I told it during the discussion. In the initial 5 years, they have showing it was not very much significant different, but when they have gone for beyond 5 years, they have shown that there is a superiority of letrozole, and also shown that the combination of AI and tamoxifen is non-inferior to only tamoxifen on AI. So this big data has given us that for postmenopausal women with endocrine responsive early breast cancer, a reduction in breast cancer recurrence and mortality is obtained by letrozole monotherapy when compared with tamoxifen monotherapy. Sequential treatment involved in tamoxifen and letrozole do not improve outcome compared to letrozole monotherapy, but might be useful strategies when considering in an individual's patient's risk recurrence and treatment tolerability. So it is a non-inferior comment, but for, as you said, it is the cost and the menopausal, postmenopausal issue. We can use tamoxifen followed by letrozole. So now the great question, what is the duration of your hormone therapy? Do you want to give it for 5 years, 8 years, 10 years, for how long?
10 years.
10 years, okay.
At a trial?
It is the Atlas trial. So they have shown, they have randomized the 5 years versus 10 years. And there were 10% was premenopausal and 25% was node positive patient. And they have shown that the 10 years is doing fairly better than 5 years, both in recurrence and mortality, and both the p-value is significant. And similarly, another trial is ATOM trial. They have also shown, and as Lima said, it is not for all group, but it was validated, the BCI. The BCI have shown that the BCI positive group is the most beneficial of this 10-year compared to 5-year hormone. And NSCPP 42 is also a study which have shown the difference, and they have concluded that we need to select appropriate patient for extended hormone therapy. So if you look at the ASCO guideline, they have taken many trials that have recommended the extended hormone, independent one hormone or combination for 8 years and for 10 years and sometimes beyond 10 years. So, and finally, they have found that there are some factors. So node positivity against node negativity, tumor size, greater, higher grade, ER positive and higher ER than lower ER, luminal A versus luminal B, and also the breast BCI, that is breast cancer index score that I told. And they have come through many recommendations. But do you know, is there any tool that can be used to predict that who will be beneficial for this extended therapy? Do you have any idea, Sonia?
Oncotype DX recurrences?
No, it is not Oncotype.
No,
it is
it
is available online. If you go to www.cts5calculator.com, if you put the tumor size, grade, patient age, and number of nodes involved, it will give you a risk of recurrence, which can help you to decide that whether you should go for extended or not. So this is another meta-analysis, and they have shown that the biggest benefit is shown in node positive, and as Lima said, it is giving DFS but not OS by giving this extension. So if you look at the guideline, it is funny. ASCO and St. Gallen gave a definitive recommendation for high risk, but ESMO said optimal duration and regimen of extended ET are currently unknown. There is only minimum benefit of use of AI for more than 5 years. So there are conflicting results. So it is not a 2+2 story. We know that there is some benefit, but still we need to select the proper patient and discuss it with the risk and benefit, and then give not all patient 10. So now we have changed that patient. It is now 20 years old, 9-year-old lady. It is T2 N1, and all the things are same, and then it is YP21. So now what will be your hormone? It is now 29 years old premenopausal lady.
Tamoxifen.
So do you give ovarian suppression, ovarian function suppression for this
With
patient?
ovarian suppression.
Okay. So this is the trial already. Today we had so many discussions, so these are all repetition. The soft and text trial, these both trial have shown the effect of tamoxifen exemestane with ovarian suppression, and they have shown that there is a difference of disease-free survival and distance recurrence-free survival, but no overall survival. The effect is not equal on group, but the overall effect is in favor of ovarian suppression. But the interesting thing is that they have shown that the exemestane ovarian suppression do better than tamoxifen ovarian suppression. So again, here we need to select and decide whom to give and discuss that we are not giving to give OS benefit, but there will be some DFS benefit. So now again we change the case. It is the 49 years old lady. It is a very small disease T1 and ERPR positive, HER2 negative, Ki-69 is 10%. Will you offer her neoadjuvant hormone therapy if she wants? Can you give her? There is a postmenopausal lady, 49 but postmenopausal.
Yes, sir.
ERPR positive, HER2 negative. Is there any scope, Sonia?
Yes, sir.
Yes.
Aromatase.
So what is neoadjuvant? We need neoadjuvant sometimes to create operability, sometimes to halt the disease, and sometimes to control the disease. But in hormone therapy, oncologically, it is impossible to have a primary optimal local treatment for T4N2 disease. But it is possible for ER-positive endocrine treatment, but not for inflammatory breast cancer. Aesthetically, it is impossible to have a conservative oncological treatment, usually for endocrine-sensitive and non-chemosensitive cancer. Statistically, we can use this approach to improve quality of care, not very clear for endocrine treatment. Now look who will be the benefited. So this is a meta-analysis of 12 trials, 11,000, almost 12,000 patients. If you look at the PET-CR, you can see that the best performer TNBC and HER2 positive hormone negative group with trastuzumab. And the worst player is the hormone receptor positive group. So we can say that PET-CR is not achieved a less likelihood for lobular histology grade 1, low Ki-67, ER positive, and luminal A. This tumor biology is less likely to achieve PET-CR by chemotherapy. So in St. Gallen 2019, they have shown the initial recommendation for tamoxifen and AI as initial treatment. Stage 1 is this, stage 2 and stage 3. You can see there is a huge recommendation to use this as an initial treatment. So they were recommending that, well, we may use this. But again, in NCCN, as what Tapash showed, that there is a possibility of using in a select group, and they are telling in 2020, neoadjuvant endocrine therapy alone may be offered to those with strong HR-positive tumor. According to NCCN panel, the endocrine therapy options include AI with ovarian suppression for premenopausal or tamoxifen. The preferred endocrine option for postmenopausal women is AI. So this is the recommendation of NCCN 2020. So it is not much practice, but it is there is a possibility. So if you this slide is shown by Tapash that this 3 trial was done, and they have shown the response is more or less equal in all these 3, letrozole, impact, and PROACT. And this trial have shown this 3 is equal. So we can say that neoadjuvant, it should be used in young premenopausal open outside, should not be used in young premenopausal open outside clinical trial. There is limited sample size, mainly on postmenopausal patient. So reliable histopathological assessment was only 12% for PO24 study. So study is not enough powered, but if discussed beyond clinical trial, it should be for menopausal patient and with AI only. So now the case is again postmenopausal. After 2 years of letrozole, patient complaint of abdominal pain, and the CT scan abdomen showed there is a 5 centimeter contrast enhancing lesion in the SOL in the liver. So how to proceed, Sonia? In this situation, what will you do? There is a treatment is done, patient is on hormone therapy, there is a lesion in liver. What do you want to do?
I will go core biopsy from the liver lesion with ERPR HER2 status.
Thank you. So we have done an ultrasonogram guided core biopsy, and liver function was normal, and the core biopsy said it is metastatic carcinoma. And again, it is ERPR positive and HER2 negative. What treatment do you want to offer? This lady.
What about the staging? What about the staging, Kamal bhai? What about the staging?
Sir, can I show?
It is a metastatic now. It is metastatic.
Yeah, but would you not want to look at the rest of the body?
No, there is no other sign, only liver.
We should do metastatic workup. And
metastatic workup is only other than liver, nowhere else. Thank you, Purit, for picking up. Sonia, answer to your question, we have done the metastatic workup. Other than this liver lesion, there is no other lesion anywhere in the body. Bone is free.
Is patient develop visceral crisis?
No. There is. What do you mean by visceral crisis?
Sir,
Okay. Visceral crisis is severe organ dysfunction as assessed by signs and symptoms, laboratory studies, and rapid progression of disease. Visceral crisis is not the mere presence of visceral metastasis, but implies important organ compromise leading to clinical indication for most rapidly efficacious therapy. Example, liver visceral crisis, rapidly increasing bilirubin more than 1.5 times on upper normal level in the absence of Gilbert syndrome or biliary tract obstruction. Lung visceral crisis, rapidly increasing dyspnea at rest, not alleviated by drainage or pleural diffusion. So,
I will go for another regimen, hormone therapy.
What?
Fulvestrant.
Only hormone? Only hormone?
Plus chemotherapy.
Hormone plus chemotherapy, Sonia?
No, sir. Can I see the previous slide?
Yes.
Case scenario.
So this is a postmenopausal lady. Initially, it was T2N1. After treatment, she was on hormone therapy. Now there is a single solitary lesion in the liver. Liver function is normal. ERPR positive, HER2 negative.
Sir, another hormone therapy and palbociclib.
Good. One hormone therapy. So, would you like to repeat the receptor test that I done? Are you agreeable to do the receptor test, or you don't want to do it?
Want to do receptor test.
Why? Okay. So you see that there is a discordance rate of 3.4 to 60% of ER negative to ER positive, and 7.2 to 31% from ER positive to ER negative, and 0.7 to 11% for HER2 positive. So retesting of receptor status of recurrent disease must be performed if it is unknown, or if it was originally negative, or there was no overexpression. We can do it, but these are the area where we must do it. That if it was initially negative, to look for if it is positive. And if it is initially not overexpressed HER2, then we need to do it to see whether there is some change. If it is not known, we should do it. Okay, so as you said, we will go for palbociclib as per Paloma 2 trial, which has shown that the only hormone CDK4 palbociclib with hormone is better than hormone alone. And that's why we will give that. So thank you, Sonia. It was wonderful. Like always, I'm proud of you, Sonia, that you are doing so much great thing. At your age, we didn't hear of anything like this. So now we are at the time of quiz. So Regan, can we go for quiz? Can you please give the link
Dr.
to
Kamal, Dr. Kamal, just I want to point out that in this scenario of single hepatic metastasis without any visceral crisis, other than the newer approach of palbociclib, is there any role of the radiofrequency ablation in this situation?
So radiofrequency ablation is recommended 3 centimeter and below lesion. This is the 5 centimeter lesion, sir. So, and we give SBRT to this, but we give after giving some systemic therapy. Say for hormone, if it is shrinking, 5 centimeter comes to 2 centimeter, some residual is remaining, then we give SBRT. Regarding the RFA, it is recommended up to 3 centimeter. Beyond 3 centimeter, RFA outcome is not very good. But there is a, I don't know, maybe somebody may think of metastatic cancer.
What about surgery?
Yeah, that was there. Somebody may think of metastatic. That I was thinking. It is a solitary lesion. There is some good data of metastatic also. Yes, Zakir bhai, you wanted to make some.
Especially after chemotherapy, of course, if it stays the single lesion, we remove it normally. Yes, surgical resection, we do that.
Yes. So as I said, any ablative treatment or surgery should be after the systemic treatment. Once it has responded, regressed, and the residual we take out, not at the beginning.
Correct. I agree.
So the quiz time is going on. Last week we had a bit less participation, around 50, but today we are happy to see more than 60 plus participation. So maybe people are not very keen for radiotherapy, but again, go back to endocrine chemotherapy, they are very keen. And even surgery. Last time surgery was almost 100 participation. Two and a half minutes left. So we are thinking that from next session, we will ask a young volunteer to make a 4 to 5 minutes presentation. So that is a new addition in our next session. It will come. So take preparation, anybody who can be the volunteer, we will invite you to make a presentation only for 4 to 5 minutes. And that will be the beauty, how you make a presentation within 4 to 5 minutes.
I'm sure that's a better idea. Khadim bhai, assalamu alaikum. খুব ভালো লাগলো আপনি যে এসছেন আপনারা আসলে তো সবাই আরো এনকারেজড হবে তাই না জুনিয়ররা এবং সিনিয়র সবাই আছি ভেরি গুড ভাই
So the next topics for the junior is what is the basic difference of AJCC 7 and 8 in breast cancer? I want a 5 minutes presentation to see what is the difference of AJCC 7 and 8. Change of what is the new in AJCC 8 compared to AJCC 7. So I need a volunteer, somebody can contact who wants to be the presenter for the next. And the next Sunday, there will be no program for the Eid holiday. We will skip the next Sunday and the subsequent Sunday will be our program. So less than 1 minute to go. Today, the quiz question, I found it was quite easy. I'm thinking that many of them will have 100 out of 100 score. And I was thinking if Ayesha get the award, how can we send the award money? that is going to be a big challenge. We need to find a way.
So whatever I'm learning through your presentation is actually the award, and I must appreciate the way you are helping your residents, interns, and everybody. You are the true role model, really.
Thank you, Ayesha. I'm fortunate to have some seniors with me and some colleagues with me. So nobody can do anything. You can see somebody like Professor Hai is on you, you can do anything. You can conquer the whole world. So the quiz time is over. Now we are in the rapid fire session. I need a volunteer for the rapid fire session.
Sir, I want to participate.
Who is it?
Sir, Dr. Nusrat.
Okay, Nusrat. So, first question. What is the benefit of 5 years adjuvant therapy?
What is the benefit of 5-year adjuvant?
What is the survival benefit of 5-year adjuvant hormone therapy? As per the Lancet 2011 publication that we discussed.
5-year adjuvant hormone therapy.
Mortality reduction in ER positive breast cancer.
Yes, sir. Mortality reduction in ER positive breast cancer.
Okay. Why we advise ER testing only in DCIS, not PR?
Sir,
only in DCIS we advise ER, no need to PR and HR2. Why
sir,
won't
if it is ER positive, then we can give the chemo prevention, the tamoxifen. But if PR positive, we don't give any treatment for DCIS.
Okay, the answer is in NSABP 24 trial, which confirmed the effect of hormone in DCIS. In that trial, the study was that the majority of the patient was ER, PR positive, and the number of patient PR positive, ER negative was insignificant. So the study result was not reflecting on only PR positive group. That's why the recommendation is not to see PR, only to see the ER. So which trial proved the ovarian ablation is beneficial for premenopausal high-risk breast cancer patient? Which trials I will write?
Soft and text trial?
Yes, soft and text trial. Thank you. So which trial first proved the benefit of 10 years hormone therapy in breast cancer?
Sir, Atlas trial, Atom trial.
Atlas. Yes, right. So what is the rate of discordance in ER negative to ER positive in recurrent breast cancer? Just now I told. Discordance between ER negative to ER positive. What is the rate?
Sir, in a CBP trial, 3.4. Yes, sir.
60%, up to 60% discordance is there. So who are the preferred candidate for retesting of the receptor status of recurrent disease? Whom we must do? Receptor, after metastasis, we are doing the retesting for the receptor status. Who are the must-do candidate?
Sir, premenopausal patient?
No, just I told. Previously unknown status,
unknown, originally negative,
or it was HER2 negative. So these are the must-do group. So what is the ESMO recommendation about the optimum duration of extended AI treatment? What ESMO says about the optimum duration of extended AI treatment?
10 years.
No, they said there is no definite recommendation. ESMO said no definite optimum duration. What is the recommended hormone for neoadjuvant hormone therapy in postmenopausal breast cancer patient? Which type of hormone you will use if you offer a patient for postmenopausal in neoadjuvant? Tamoxifen or AI?
AI.
Yes, AI, thank you. What is the contraindication of first-line hormone therapy in HER2 positive and hormone receptor positive and HER2 negative metastatic breast cancer patient? Say it is a HER2 hormone receptor positive, HER2 negative breast cancer patient, but you should not use hormone of the first line. What is the contraindication? If the patient has visceral crisis, then we cannot give to hormone. We need to go to direct to chemotherapy.
Direct to chemotherapy.
The factors considered by CTS5 calculator to assess the risk of recurrence of breast cancer. I have shown you the online calculator. In that calculator, what are the value we give? 4 value. Let me help you. 4 value we give. What are the value? What are the parameter?
Sir, age.
Age. Good. Okay.
Sir, I can't recall.
Tumor size, grade, age of the patient, and number of nodes involved. So thank you. You have done really great. I could say that 100 out of 100. Thank you very much. So now we want to go to the vote of thanks. I think Lucky is there. 1 minute for you to say vote of thanks, Lucky. Sanofi.
I always took 1 minute, sir.
Yes, please.
Thank you, sir. It's my honor and privilege to have the opportunity to give vote of thanks. I must say one thing, this weekly online session is the most interactive and updated knowledge dissemination program that we have organized and observed in COVID situation. Sanofi feel proud and honored to be the part of this program as a scientific partner. Dear Honorable Professor, respected overseas guest faculties, speakers, distinguished doctors and others healthcare professionals, greetings from Sanofi, Bangladesh. I would like to express our profound gratitude to our Honorable Professor Muhammad Abdul Hai Sir, President of Oncology Club, for blessing us with his gracious presence. Heartiest thanks to Dr. Tapash Mitra, Associate Professor, Department of Radiotherapy, Chittagong Medical College and Hospital, for his excellent and precise presentation on endocrine therapy in breast cancer management, which is well discussed in the session. I must mention our deep sense of appreciation to Dr. Tapash Mitra for covering all the relevant aspects of endocrine therapy in a simple way. On behalf of Sanofi, I would like to express heartiest gratitude to the all honorable foreign delegates, Dr. Muhammad Zakirullah, Dr. S.K. Farid Ahmed, and Dr. John Konebier for their gracious presence and expert opinion. A special thanks to mastermind of this program, Dr. AFM Kamal Uddin, Scientific Secretary of Oncology Club, taking the initiative to organizing such lively interactive session. Heartiest congratulations, thanks to my colleague Nahid Hassan Abbas, especially Shadat Hussain Rigan for their support and cooperation to organizing the program. On behalf of Sanofi, I would like to give a special thanks to all participants for took up their valuable time from current busy schedule. We highly acknowledge your support and contribution to our society. With all of your support, we will continue this program in future. Till then, stay safe, stay healthy. Thanks for patience here and thanks to all.
Thank you, Lucky. Maybe you took slightly higher than 1 minute. Okay, that is okay, fine. So now we want to thank all our foreign faculties, local faculty, and special thanks to Professor Khadamul Islam sir for joining us. Sir, your presence really will encourage us. Thanks to Ayesha for joining from Pakistan, making it international from national, and our technical team, Regan. So today the winner is Dr. Debraj Chakraborty. Even there was another 100 score, but the winner is Dr. Debraj Chakraborty. So congratulations, Dr. Debraj.
Thank you, sir.
Can you see you? We want to see you, Debraj. Please come to the screen. Yes, please. So I think it is your second win.
No, sir, first win, sir.
Debraj, can you unmute? Hello.
Yeah, sir. First win, sir.
Can we see you? Where is
First
Debraj?
win. Okay.
Yes, we can see. We can see.
Yes.
Nice, please.
Oh, we can see you. Congratulations, Debraj.
Thank you, sir.
Congratulations.
That you have done a wonderful job. And now we want to go back that, as I was mentioning, that our next session will be on metastatic breast cancer management. And our expected speaker is Dr. Sadia Sharbin, but we will reconfirm it. And we are expecting all the 3 faculty, but it will not be on next Sunday, but the following Sunday. That is on, I'm not wrong, on 9th August. And we have few more items to pending, that is how to keep your data and post-mastectomy radiotherapy and uncommon histopathology of breast cancer. So after this metastatic breast cancer, we will have this how to keep your data by Dr. Zakirullah. We will have that session. So with these few words, with the permission of Professor M.A. Ayesha, sir, if you allow, can we finish it, sir?
Surely. Well, thanks to everybody, particularly Professor Khadim Islam. He has joined us first time in our sessions, and to our foreign faculties, participants. Allah Hafiz.
So thank you very much. Allah Hafiz. See you on 9th and stay safe till then and enjoy the holiday. Thank you very much.
Thank you.
Bye bye.
Eid Mubarak. Eid Mubarak.
Eid Mubarak.
Eid Mubarak, sir.